Okay. Take it away, Anne. I'll let you introduce yourself and your project.
All right. Hi, everyone. My name is Anne Hinrichs, and today I'll be presenting on the two projects I worked on this summer. First, a proposal for a community-based mental health training program for schools, and second, a follow-up process for the ongoing cervical cancer screening project with PACH and FIBUSPAM. All right, thank you all for being here. I want to take a moment to introduce myself and tell you a little bit about me. I'm Anne, although I've been on here in Ecuador. I grew up in New York City, and I'm a rising junior at Princeton. And I'm majoring in neuroscience and getting a minor in global health and public policy. Some fun facts about me are that I love yoga, cows, coffee, and hiking. And this is a picture of me before climbing Chimborazo with some of the other PACH interns and my host family. So what brought me to Partners for Andean Community Health? I first learned about PACH's work from Mariela Diaz, one of the directors of the International Internship Program at Princeton. I told her that I was interested in traveling to Latin America and working in global health, and she immediately told me about the PACH summer internship and about the cervical cancer screening initiative started by Hilal Achman. And the project stood out to me because of the Ecuador-specific statistics that inspired it, how its impact has been quantified, and how it's continued to evolve over the last 2 years. I think overall, I'm drawn to the way that PACH prioritizes community needs and the continuity of its efforts. So I was eager to join PACH in supporting ongoing projects and also to learn the framework to design new ones with the help of Zach, PIBUSPAM, and other partners. And I was also interested in learning about Ecuadorian perspectives on health and how they differ from what I've observed and experienced in the US. I have a particular interest in mental health, and I was wondering about how Andean perspectives of health might inform mental health care practice and policy. And finally, I've studied Spanish in school for many years, but I've never had the opportunity to live in a Spanish-speaking country or speak Spanish at home. So I was really excited to fully immerse myself in the language here. All right, time to delve into my first project where I explored mental health in Ecuador. I came to PACH already with an interest in mental health, but it was really important to me to understand the topic in the context of Ecuador rather than relying on the US-based knowledge that I already had. So from what I found, what makes mental health a critical area of focus in Ecuador? Well, first, there's a severe shortage of mental health professionals in the country, with only 0.08 psychiatrists available per 10,000 Ecuadorians. And that scarcity is more pronounced in rural and indigenous areas where access to healthcare is limited in general. I also talked to women during caravans who confirmed that more remote areas, some of them don't even have access to one clinical psychologist, nor psychologists in schools. And to make matters worse, stigma surrounding mental health issues prevents individuals from seeking the support they need, even when there is a psychologist. So stigma coupled with geographic and cultural barriers altogether exacerbate the existing obstacles to accessing mental health services in Ecuador. And the consequences of these barriers are pretty severe. The suicide burden in Ecuador is 7.1 per 100,000 people, and suicide is one of the leading causes of death for adolescents. And trauma, substance use, and depression impact many, many young people, partly because they don't have the language to name what they're going through, and that also inhibits them from receiving support. So this is a graphic that was published in 2022 by the Ecuadorian Neurological Review. And to me, it provides a pretty striking depiction of limited access to psychiatrists in the public healthcare system. Psychiatrists in Ecuador are doctors, so they've attended medical school for 6 years. They spend a year doing rural service, and then they have to pay for a residency program. And to distinguish between psychiatrists and psychiatrists are able to prescribe medications while clinical psychologists can't. So my project aims to address the gaps in psychiatric professionals by training community members to better recognize mental health challenges and to support people in non-clinical ways. In the next few slides, I'll talk about some of the work I did to develop this project and strategies that I believe we can take to enhance mental health support in Ecuador by collaborating with local stakeholders. So the first stage of my methods for the mental health project involved a lot of information gathering. Previous PACH interns have compiled information about the mental health crisis in Ecuador, but no one had yet solidified a plan for moving forward and also for measuring progress, which to me is really important for continuity. So my process started by reading articles and writing up an annotated bibliography. And along the way, I wrote down questions and identified individuals I wanted to have further conversations with. And the next thing I did was hold stakeholder interviews where I prepared formal questions for the individuals, but then I ended up using the conversations as more relaxed opportunities to gain some perspective and insight, and that informed later questions that I had for those informants and my overall proposal for the project. But three of my most influential initial informants include Dr. Cory Pomacaro, who's an Ecuadorian medical doctor that is studying for step 1 right now, and he intends to complete psychiatric residency in the US and then return to Ecuador to practice as a psychiatrist. I also spoke with Dr. Gloria Muyo, the clinical psychologist at FIBUSPAM, and she works with a variety of individuals in and out of the hospital, but all older than 6 years old. And I also spoke with Carolina Espinosa Cuyas, who is an Ecuadorian clinical psychologist, and she's currently getting her second master's degree in the US. Also, pretty early in my project development, I did a mental health first aid training for youth, and this was hosted by a US-based organization called the National Council for Mental Wellbeing. My goal in doing that was to get information about what a first aid model for mental health support even means, what it looks like in the US, and then how it might be relevant in an Ecuadorian context. And then after I gained an understanding of the biggest mental health challenges and some of the barriers to access, I moved on to doing a needs assessment for mental health in Ecuador with focuses on youth and women as audiences. After the needs assessment, I decided that a strong potential solution to support community health in a way that would be low cost and low infrastructure was to develop a plan to train existing community leaders with mental health support skills. And this was definitely inspired by the model of US mental health first aid, where you're training people like teachers and social workers and different community leaders in recognizing mental health challenges in different types of populations. So with that idea, I moved on to a feasibility plan for 2 different audiences. I had a youth-focused track and a women-focused track. And the feasibility planner was really helpful because it brought up a lot of questions and concerns that I would later need to address in my implementation phase. On the right here, I just have a little screenshot of my purpose statement, which at that point when I was drafting it focused on youth and women, although eventually I narrowed into youth. So my research and design process about the landscape of mental health across Ecuador had 5 central findings. The first was that I was really surprised to learn how limited the resource of psychologists and psychiatrists are here. Particularly my conversations with Dr. Cory Pomacaro taught me that psychiatry residency and medical specialization in general isn't feasible for the vast majority of Ecuadorians because it's not paid, but it also costs money. So for psychiatry residency, it costs at least $20,000 and requires 4 years of training. So although that knowledge was really motivating, I knew that my goal in my project wasn't going to be to increase the number of psychiatrists in Ecuador, and I needed to find some other kind of solution. Also, my conversations with Dr. Muyo, because she works with younger people and adolescents, taught me that school counselors here are not allowed to give therapy, so students have to be referred to outside psychologists for care. And there are several reasons for this, but primarily it's due to legal restrictions, and then also because school counselors, just one counselor, can be responsible for up to 1,000 children. But then different reasons such as a deficit of private and public psychologists outside of schools, parental distrust in psychological services, and cost end up being a deterrent for students who are referred outside of school to get care. The third finding that I would like to talk about is that the clinical psychology system itself here has some variable quality and inconsistent regulation, which creates a further challenge in developing and delivering effective psychological care. I learned a little bit from my interviews about how legislation here of psychology as a field is less stringent compared to the US, which means that sometimes youth receiving psychological care, particularly in schools, get care that does more harm than good. Culturally, machismo presents a barrier, particularly for boys here, who often don't have the emotional vocabulary that they need to express their feelings, which can hinder early intervention and support. And my conversations with informants gave me some insight into how common this machismo culture is and some of the consequences of absent conversations about mental and emotional well-being. So part of my goal in this mental health training for teachers is for them to provide language as a tool for youth to better recognize their own feelings and to normalize expressing themselves earlier on. And lastly, for findings, there seems to be a pretty strong equity issue in that Indigenous communities are notably underrepresented among those seeking psychological services at PIBUSPAM. And to me, this highlighted a need for more culturally sensitive outreach and psychological services. I was surprised to learn from Dr. Muyo that over the last several years, there have only been a couple of Indigenous patients at PIBUSPAM seeking psychological services, which led me to the question of whether Indigenous Ecuadorians are just not experiencing mental health challenges, or whether they lack the language to talk about them, whether stigma is a deterrent, or if there's some other explanation. But altogether, these findings underscore a need for more comprehensive strategies to increase community-based mental health support. And in the next section of my presentation, I'll talk about some of the potential solutions and partnerships that I hope would address these challenges. So now to talk about the actual program I designed this summer and how I hope it could be carried out in the future. My working name for the project is Youth Mental Wellbeing Training Network, or Red de Capacitación en Bienestar Mental Juvenil. And first, it's important to know that having at least one trusted adult a child or teenager can confide in is one of the biggest protective factors against mental illness. Some youth do find this in parents, but many rely on their teachers, sports coaches, or other adults outside of the home. And my main goal in my project is that schools, regardless of the resources they have or access to clinical psychologists, have teachers with the language, tools, and resources to be trusted adults for their students. And then in order to accomplish this, my idea is to develop a mental health education curriculum that equips teachers to recognize and respond to youth mental health needs. I hope that this curriculum would be comprehensive and interactive and include training sessions for teachers and other school staff covering topics like identifying early signs of mental health issues, effective communication techniques, and strategies to provide those initial stages of support and guidance. The plan that I have right now for curricular development emphasizes collaborating with local mental health and educational professionals who could hopefully offer their insight and resources tailored to the specific needs of the community. But with all that being said, one of the non-negotiables of the curriculum and implementation of this project is to integrate Andean perspectives of mental health throughout. So the full implementation of this program that I'm envisioning will require a sustained effort in terms of curricular design, the training process, follow-up, and then hopefully a curricular redesign eventually. But my goal this summer was really to set up the information and a formalized plan necessary for implementation by a future interested intern. So what do the next steps look like? Well, first, I hope Ecuador conversations that I started, particularly with Carolina, Dr. Pomocaro, and Dr. Amuyo. And I also believe that in order to achieve a successful curricular integration with Indigenous Andean perspectives, we need to collaborate with an outside source outside of FIBUSPAM. And I think Hatunwasi, the university, is a promising candidate for that kind of collaboration. Another important initial step will be to develop a contact with the Ministry of Education to determine which schools are feasible partners for the initial rollout of the program. So now that I've introduced the recommendation, being the Youth Mental Wellbeing Training Network, I want to spend some time talking about the logistics of implementing this in the future. So first, the intern that takes on this project must continue outreach efforts to informants from PACH, FIBUSPAM, and also likely Hatunwasi. And this ongoing partnership will hopefully facilitate design, review, and updates to the training material as the program grows. The next phase is the curriculum design process, which is going to require input from clinical sources like Dr. Muyo and Carolina, Andean health leaders, legal professionals, and also translational support for the educational materials. And then once the curriculum is developed, it'll be necessary to build referral pathways with resources that trained teachers can direct their students to. Also, PACH interns are likely to be serving as the instructors for the teachers, so they must be trained and the schools must be identified before the training can actually be delivered. And finally, in stage 4, once the initial cohort of teachers and school staff have been trained, I believe it's important to stay in close contact with those schools. So in my implementation plan, I recommended a monthly follow-up protocol, also a review of the collected data from trainings, a record of notes from follow-up conversations, and also a record of any referrals that are made. And I think it would be valuable to use all of that feedback that I just mentioned to create a refresher training that could be given on an annual basis. So as I come to the end of this portion of the presentation, there's some questions that will have to be answered for the success of this mental health support project. First, what would curricular co-design with Hajimwasi actually look like, and how could we best use them as a resource to incorporate Indigenous perspectives on mental health into training curriculums? Second, if one of the trained teachers encounters a student who they believe needs a referral for professional psychological support, what does the referral process look like? And does every school already have access to a psychologist who could and would make this official referral? Also, would we legally be able to record how many referrals are made? And for a third question that I have is, what strategies can we use to address mental health stigma and also teachers' very busy schedules as obstacles for community buy-in? And then my final question is, how can we ensure a continuity of training personnel if the majority of the trainings are delivered by PACH interns who are here temporarily, either for a few weeks, 8 weeks, or sometimes for a year? Right, so the second audience that I believe could benefit from this type of non-clinical mental health support training model are women. And one of the roles that I had during one of our recent medical caravans was to engage in charlas, or conversations with the women waiting to receive cervical cancer screenings. The charlas were primarily facilitated by Carolina, who is an Ecuadorian clinical psychologist working with PACH, and there was also a US-based psychiatrist facilitating. In particular, during our caravan to Chambo, I heard from several women that they didn't have any local psychology services, and also that they tended not to have difficult conversations about emotions with their friends, but rather some found support in religious faith and others from family members. But what they expressed was a desire for an organized space to come together with other women and to share openly. Something that surprised me from these conversations was that they were interested in having a professional from FIBUSPAM to help direct the conversation, which was partly to facilitate with their professional skills, but also partly to avoid gossip from the community that might come if they organize themselves independently. And they were also interested in having an activity like knitting or crocheting to help encourage conversation. But with that being said, I hope a future intern will use what we learned from these charlas to inform a future project that supports women's mental health by educating community members and empowering them to come together and support themselves. All right, so I'm now going to shift gears into the second project that I worked on this summer. I mentioned earlier in my introduction that the project that first inspired me at PACH was the cervical cancer screening program. And I was interested in understanding where the project currently stands and also how it might evolve moving forwards. So for a little background, cervical cancer is one of the leading causes of death for Ecuadorian women, and Hilal Achman, Princeton class of 27, started this project in 2024 to increase access to diagnosis and more timely treatment through the Caravana model. Over the course of 2025, 584 women received screenings during caravans. And in these screenings, there's 3 outcomes. Either women don't have any sign of cancer, or women have a low-grade cervical cancer lesion, and they're able to receive thermocoagulation on site, which stops growth for up to 5 years. And then the final group of women are women who have the diagnosis of a high-grade cervical cancer lesion, which means they're not candidates for thermocoagulation on site, and instead they're recommended by FIBUSPAM gynecologists to get biopsies to determine what the next steps are going to be for treatment. However, given what we know about the challenges of accessing follow-up care after caravans, my next question was, are women with high-grade lesion diagnoses getting the biopsies that they need? And for those who are not, what are the biggest obstacles? What are the biggest barriers? And so my second goal was to find an effective but also compassionate way to provide women information about the biopsy process, why it's so essential, and also where they can get them. I recently, just a couple days ago, joined a Zoom from the American Cancer Society, and I learned how important patient navigation is to addressing disparities in cancer outcomes. So part of this project is about patient navigation for these women who are getting the screenings through our cervical cancer screening project. So I worked on this project in collaboration with Amelia Haymack, who is one of the incredible Princeton Latin America Fellows, and she was an invaluable resource to me and to all the interns during our time here. But together with Amelia, we identified 34 women who were diagnosed with high-grade cervical cancer lesions during caravans in 2025. All of these women were recommended to get a biopsy, but they unfortunately didn't get any follow-up information from PACH or FIBUSPAM after they were diagnosed. So one of the first things that we wanted to do was to understand what types of health centers offer biopsies, what the process of scheduling an appointment looks like, and anticipated average costs. The 34 women we identified came from 11 different caravan locations. So our first step was to locate the health centers near them. And we identified 3 types of health centers. First, Solcas, which is a private cancer hospital system. They're considered really the gold standard for cancer treatment. We also looked at public hospitals and also non-Solca private hospitals and clinics. In total, we contacted 29 health centers, and I'll talk a little bit later about what we learned from those conversations. But I also want to mention that 2 of the individuals from FIBUSPAM who were really important contacts were Dr. Rodrigo Hinojosa, who is both a family medicine doctor at FIBUSPAM and is also trained to give cervical cancer screenings during the caravans, and also Magister David Guacho. So the 2 of these men contributed essential perspectives on how to convey the biopsy information that we wanted to give in the education, but without giving FIBUSPAM any clinical or financial or legal responsibility that we can't take on. So there are 2 tangible deliverables of this project. First being a WhatsApp message that we've drafted to send out to women who receive a high-grade lesion diagnosis, and also an informational video. So I have the text of the message pictured on the right, but some of the key components of our communication are first to confirm the identity of the woman receiving the message, because we've learned that here it can be common for families to share one phone number, and this is very personal medical information. The next part is to state that our goal is really just to know how they're doing and provide a little bit of information. We also ask if they've been able to get a biopsy, and then if they have not gotten a biopsy, we are going to provide all the details for the nearest cancer hospital, the nearest Solca, and also information about the public hospital route. In the next message, we encourage them by saying that biopsy is one of the most protective steps they can take for their health, and also that we're available for questions. And part of my work this summer was to figure out what some common frequently asked questions might be and how we could answer them. And the next piece of the message, the final piece, is an informational video that aims to convey similar encouragement and information, but in a visual format. So I wrote the script for the video, and then with Zach's help, we used the AI tool 11 Labs to help generate the graphics, and there's a little screenshot of the video on the left. The next thing I want to talk about is what we learned from the local health centers and how we determined exactly what information to include in our messaging. So this chart represents the 3 types of health centers we contacted over the last few weeks and what we learned about the process of obtaining a biopsy. The most surprising and ultimately for me really frustrating finding was that it's going to be most likely impossible to get a biopsy with just one appointment, partly because the colposcopy images taken during caravans aren't saved, so patient records just include a clinical drawing. For Solca hospitals and for private clinics, patients will likely start with an initial consultation appointment with a gynecologist, and that'll be appointment 1, and then appointment 2 will be a separate appointment to get the biopsy. But for public hospitals, women will most likely have to start with a general medicine appointment to get a referral to a gynecologist. And then with that referral, they can make an appointment to get the repeat colposcopy and then an appointment for biopsy. So a 2 to 3, maybe potentially 4-step process like this is likely going to pose barriers in terms of cost and distance, particularly for women who have to travel far away to go to the clinic for each of these appointments. Right, so after my research and my work with Amelia this summer, there are several remaining questions to consider regarding cervical cancer screening follow-up. First, although we got average costs from a few of the health centers we contacted, many of them were unable or unwilling to disclose expected costs, so it remains unclear how accessible the cost of cervical biopsy is going to be for the average woman who attends one of FIBUSPAM's caravans. The second question is about the biopsy process through the public health system. I wonder and sincerely hope that there's going to be a possibility to circumvent the need for multiple appointments, being the general medicine, then the colposcopy, and then the biopsy. And finally, I wonder if there are barriers besides knowledge, distance, cost, and stigma that are causing women who receive diagnoses of high-grade cervical cancer lesions to not get their biopsies, and potentially is family pressure another deterrent? And so could communication with families maybe also be a way of supporting that women get biopsies? But my hope is that the women we follow up with through WhatsApp are going to provide further insight about either how they were able to get a biopsy, which would be the best case scenario, or if not, what ultimately prevented them from doing so. So the cervical cancer screening project, or the follow-up project, is going to be carried out by the next Women's Health Princeton Latin America fellow, Marion, and I'm really excited to see where she takes this work that we did this summer and really all of Hilal's work from the last 2 years. But the next step in the project is to send the follow-up messages to the 34 women we've identified via WhatsApp to document all their responses and also to answer any questions that come up. I also think it's necessary to create a formal protocol for more regular check-ins after the caravans for the women who have high-grade lesion diagnoses. And this might look like a schedule for sending WhatsApp message reminders with information and encouragement to get a biopsy, maybe 1 week after the initial caravan or every 2 weeks. Also, during the American Cancer Society call, I learned about one organization based in India that is working on cervical cancer elimination and increasing the rate of or the prevalence of screenings and treatment. And they check in with patients the day before the screening and the day after the screening, and they also follow up through the treatment process. So learning that made me think that we probably have a lot to learn from other international groups who are also committed to cervical cancer prevention. And then finally, I think it'd be valuable to consider the possibility of saving the colposcopy images that we take during caravans to include in patients' electronic medical records. Even if it isn't feasible to save all of the images, perhaps we could save just the images from high-grade lesion patients. And my hope in doing that would be to circumvent the need for a repeat colposcopy because we could provide the hospital with a more complete medical history for every patient. So I'd like to wrap up now that I've talked about my projects with some reflections on the summer overall. And I'd like to say that this summer has, without a doubt, shaped the kind of doctor and adult that I hope to be one day. I think a lot of that came from my shadowing experiences in and out of FIBUSPAM and the caravans. I got to help take the colposcopy images during the cervical cancer screening caravan with Dr. Hinojosa. I got to assist Dr. Lennon with dental cleanings. I got to scrub into strabismus surgeries with the Siegel group. I got to observe pterygium surgeries with Dr. Pinuisaka and watch a gallbladder removal with 211 stones. And I also got to interpret a little bit for general medicine consults. And I think in all these experiences, I had the opportunity to see how patients build trust, or how doctors build trust with their patients, and also how resources like medications and sterile tools are optimized in a really creative way when they're limited. For my project design, I learned how important it is to have early conversations with the people in the community you hope to serve. I'd say that the decisions and the pivots that I made along the way, starting with my information gathering and the mental health needs assessment, were inspired by the conversations I had with informants at the very beginning. And for instance, my decision to narrow the mental health project to a youth focus came from what I learned from the people I interviewed. Finally, I'd also like to mention that I'm really grateful for all of the experiences outside of the clinical and project work, living with my wonderful host family, trying cooking new foods, learning a little bit of Quechua, and also getting to see some of the most beautiful sites in Ecuador. Those are all memories that I'm going to cherish and bring back with me to the US. And finally, I'd like to say that all of the wonderful parts of this experience are thanks to the support of the people here in Ecuador and back in the US. So I'd like to extend my thanks to Zach at PACH, Amelia Haymack, all of the doctors and nurses and staff at FIBUSPAM for welcoming us and being so helpful, my fellow interns, and also my incredible homestay family to all of them for filling my time in Ecuador with so much learning and also so much adventure. Yupai Chani, which is gracias or thank you in Quechua. Thanks for listening to me present on what I've been up to these past 8 weeks, and would love to welcome any questions about my project work or my experience.